everyone. Thank you so much for joining this webinar. This one's going to be a little bit different. We're not talking about one specific topic. We're going to talk about how we approach cases with pretty non-specific clinical signs. So if we think about it, many cats present to clinics, be that primary care or referral actually, with lethargy, hyperexia, weight loss. We could maybe add to that very intermittent GI signs, something like that. These very non-specific signs. There are loads and loads of differentials for these, and it can be really challenging to know where to start and which tests are going to be the most optimal. And that's particularly difficult in financially limited patients where we need to be really careful with the tests that we choose. We can't just throw everything at them. In this talk, we're going to really use a case-based discussion, and I'm going to talk to you about how I approach some cases when I've got things wrong, and when I have missed things out, and just go through kind of how we work logically through these type of challenging presentations. So let's start with a case. This is Rory. I haven't got any brilliant pictures of him because he's constantly moving, and so I've already got blurred pictures of him mainly, but he's a 9-year-old Bengal. He's an only cat. He is vaccinated in worms, and he spends a lot of time outdoors. And he's got a 2-week history of some pretty vague clinical signs, so lethargy and hyporexia, and that's all that we've got to go on. That's all that's been reported by the owners. Now, during his investigation, he'd had a little bit of treatment at the referring vets. He hadn't really responded. He'd developed quite a mild cough, and he'd had some X-rays done at the clinic, which showed a very, again, non-specific finding, a mild to moderate bronchointerstitial pattern. Now, he was treated with dexamethasone, and that was followed with some oral prednisolone, initially at 2 mg per kg and then reducing to 1 mg per kg on the basis of a suspicion of feline lower airway disease. Now, just remember his initial clinical signs of that lethargy and hyporexia. You might agree with me that that's a little bit atypical for primary respiratory disease to present with those clinical signs before the development of cough. And so the pattern of clinical signs, we're going to talk about this in another case later, but that pattern of clinical signs can be hugely useful. Anyway, after this treatment, after about a week of steroids, he deteriorated. He was severely tachypneic. His cough had worsened, and he was really doing quite badly. He'd lost some further weight as well. He came in as a referral case, and his blood showed a moderate neutrophilia. We did perform a CT of his thorax, but I think we still would have found lots on just repeating X-rays. But we did do a CT, which showed some focal areas within the thorax of kind of increased opacity, and that's consistent with basically you've got too much fluid or cells there, so it could be a focal pneumonia, unlikely to be neoplasia, etc., etc. We did do a BAL, which showed just quite a lot of neutrophilic inflammation. So that's where we are at that point in his investigation. So my question to you is, when we look back at this case and we look back at how we approached this case and how the case was approached originally, did we miss anything? So spot the deliberate mistake. What do you think? Well, something that's really important, and that's a dietary history and a little bit more information about lifestyle. And what I mean by that is understanding what a cat has been fed previously and what they've been fed during their period of illness. And in this case, he was a raw fed cat. He was fed with both commercial raw fed sources as well as some sort of meat from butchers, meat from supermarkets. So quite a varied diet. But also he was a really big hunter. So he was a hunter of rodents and birds and was constantly bringing things back as Bengals or, well, my cat does as well. He's not a Bengal, but Bengals sometimes can be quite prolific and powerful hunters. So that history, does it change anything? Does it introduce any other differentials knowing that? Well, I think it does, and that's why the dietary history in non-specific cases can still be very important. I'm aware that Rory did develop a cough, which was at least helpful for directing our investigation. But without this particular history, we might not have some differentials particularly high up on our list. So let's think about what differentials raw feeding or prolific hunting as well might introduce to a case like this. Well, let's think about, of course, infectious diseases is going to be number one. And we also need to consider whether those diagnoses would fit the clinical signs and progression of his illness. So we can see that actually any infectious disease would be likely to worsen with immunosuppressive prednisolone treatment, of course. And so that bit of history and that response to treatment is very, very useful. So I'm thinking about things like toxo. We have had many reports now, sadly, of mycobacterial infection in raw fed cats, and a recent spate of cases in the UK, in particularly young cats presenting with respiratory disease that have been raw fed. And we also had a history of M. bovis cases and other mycobacteriosis cases in the past associated with particular outbreaks and particular sources of raw food. But also, that hunting behavior brings in a whole other list of differentials that wouldn't necessarily be present in a cat that wasn't so much of a hunter. So things potentially if they eat a lot of birds, like salmonellas and all this type of thing. And so even actually what they're hunting can be useful. Lungworm is something that we don't see very much in the UK. In other parts of the world, you might see that more frequently, but again, a real association with hunting. So this was a crucial bit of information that actually, when we went back through all of the history, that had never been asked. So the owner hadn't, of course, volunteered that information because they would not necessarily understand the significance. And so just a really, really vital bit of history taking. When we think about these differentials, we've then got to think about how we potentially are going to test for them. And we could test for Toxoplasma in the serology, so we can have a look at antibodies to Toxoplasma. But you can also do a PCR test on the BAL, and that has actually been very useful and diagnostic in some cases for us. Mycobacteriosis can be difficult to diagnose. We may find evidence of lymphadenopathy, we may find evidence of changes elsewhere in the cat's body. And again, we can look for ZN staining within the BAL, for example, and we can submit the BAL for PCR testing for mycobacteria as well, or we could consider doing some blood testing, some interferon gamma testing for mycobacteriosis. Now, I'm really aware in this talk that I'm not getting into great detail about each one of these tests, and I don't quite have time to do that. So please think of this as just an overview of these cases and the take home messages from them rather than specifically about, for example, Toxoplasma infection. But we did run serology on Rory, and I could have run a PCR on the BAL as well, certainly. But in this case, we did find some pretty high levels of antibodies to Toxoplasma. Now, antibodies themselves in the diagnosis of toxoplasmosis are problematic, and we know that they're not always the most accurate. But I think you'll agree that these very high levels, with his history and his clinical signs, would raise severe concerns for Toxoplasma. So I think with history taking, it is really important to spend that little bit of extra time in these non-specific cases. And I suppose I have a standard approach to cases, and I'm very aware that I have a longer time to talk to owners than in primary care, but I would start at the beginning and the origins of the cats, and sometimes that can be quite useful. We see cats that are from overseas these days, and actually this image here is a CT scan from a cat with Toxoplasma. Again, different cats, but this cat was from overseas, and it had actually been an indoor cat all of the time that it had lived in the UK. It had never hunted, but its origins were from overseas within a shelter and from a street environment. So just taking a snapshot of current history might not have been as useful as really asking about where that cat came from. So we need to think about that travel history these days more and more. Pets are being imported. We know that in the dog world, but it's actually growing as well in the cat world. And so we need to ask those questions. Lifestyle is something we wouldn't ask in dogs, but is really important to ask in cats. So, do they have outdoor access? Have they ever had outdoor access? And of course, that hunting behavior is going to be connected to that as well. We want to know about other pets in the home. We know that occasionally there are pathogens that can transfer between species, but we also want to know if there are a number of cats in the home and what their health status is, and that dietary history that we've talked about. Things like preventative healthcare I'd routinely ask for, as well as to whether they've had any recent wormings, vaccinations, etc. And medication. Obviously, in this case, I had the history and I knew this cat had been treated with prednisolone. But in some situations, and particularly in some other countries where owners do visit more than one vet, so there can be a little bit more of a pattern. For example, I understand in the USA of sometimes visiting an out of hours, sort of they call them an ER clinic, and then visiting other clinics for different things. And so you might have a gap in history taking as far as prescribing in that situation. So the uniqueness of cats, we've got to be even better at taking our history. Okay, let's move on to another case. And I told you I'm going to jump you through some cases here and hopefully with some take home messages. This time we've got Maisie. Now I did talk about Maisie at a clinical club recently. So if you did hear me talk about that, I apologize for being repetitive, but I think illustrates a really good point. Maisie is a 12-year-old Burmese cat who is indoor only. She's relatively up to date with vaccination, although technically has lapsed a little bit of time. She lives with one other cat that is healthy. Her diet is unremarkable. It's a complete food, but again, that's important to know. Sometimes I'll see it written down that they're just on a complete diet. Fine. I actually want to know the brand and whether they're wet or dry. That can be important. And she's been a generally healthy cat in her life. And I think probably this photo tells you that she's not healthy at the time that we see her. So last week she developed some upper respiratory tract signs and had an injection of long-acting antibiotic, which we can argue sometimes not the most fitting to that situation. But she seemed to improve. There was there was no other history that was remarkable and causing any concern. However, now she has been hyporexic. She vomited once, so vomiting doesn't seem to be a frequent thing, but she's got no other specific clinical signs. But it's quite out of character for her not to eat, and so this has alarmed the owner. So again, relatively non-specific presentation with a little bit of an odd history. On her exam, she's pretty quiet, pretty flat. She looked maybe a little bit nauseous, exaggerated swallowing, and kind of some thick saliva in her mouth. And it's always worth just stepping back and trying to watch cats for a minute whilst the owner's giving you the history, because you can learn a lot about, especially if they're loose in the consult room, about gait and demeanor, etc. She had some urine in her bladder. Her upper respiratory signs seemed to have nearly resolved, but there was a little bit of nasal discharge. She's not dehydrated. So, again, the physical exam obviously useful to give you information on how urgently you need to investigate and how critical the patient is if they need treatment. And in this case, her blood pressure is normal, hydration is normal. Got some bloods for you here, and you can see that she's azotemic, she's hyperphosphatemic, and she's also got a really high total calcium. So forgive me if these units are less familiar to you, but I've converted the creatinine so that you can see that we've got quite a significant azotemia here. The hematology is relatively unremarkable. The neutrophilia is pretty mild. Got a mild lymphopenia. And then we have got mildly low platelets. And I hope you're all shouting at me, well, check a smear, because that's what I'm always going to tell you. So many of these machines, including the one we have in our clinic, will measure platelets low in cats and not taking into account clumping. So we did do some imaging of her kidneys on the basis of that azotemia, as you'll imagine. It's given her hydration status, pre-renal causes unlikely, so we're left with renal and post-renal causes. Difficult to relate to her original presenting signs. Perhaps they were, not relevant to what's going on now. And on this, we found some slight changes. So bilaterally hyperechoic renal cortices, little bit kind of the fat looks a little bit bright in that region as well, looked all kind of very inflammatory and much less like lymphoma. There was a medullary rim sign, which you can see on here, and that's quite a non-specific ultrasound finding. It's often seen with CKD and in older cats. You can see it in other toxicities and things like FIP, but it's very non-specific. So, what's next? Well, I'm sure you want to do some urinalysis so we can try and see if that gives us any clues. And we've got a very mildly increased UPC. We've got a little bit of blood in there. Nothing too exciting as a cystocentesis sample, so it could be some contamination. But the ionized calcium is also really high. So we've got a very significant total and ionized hypercalcemia. We also had a hyperphosphatemia and a moderate azotemia. So quite a kind of complex set of results to untangle. So is this acute kidney injury? Well, it certainly could be. We don't have, she's never had bloods done. There are things that point away from chronicity. And again, this is really important part of history taking and physical exam. We're looking at anything that suggests the duration of this illness might be longer than the owner's reported history. And that's an important point. We often talk about cats hiding signs of illness, and actually, they don't really hide signs of illness. I think we're just a bit rubbish at recognizing them sometimes. And also, we don't take them for walks. We don't necessarily expect them to finish their dinner all in one go. And all these expectations can be a little bit different than dogs. So a keenness of a dog to go on a walk or lack thereof would be an immediate alert that something was going on. And in my dogs, certainly if they didn't eat their dinner, I'd think they were pretty near death. So we don't have those little bits of history. So we've got to ask about kind of previous body condition and current body condition. We've got to see if there's any history of changes in behavior, which can be really important. That can be even just sleeping somewhere different. It might not be PUPD. I had a case the other day that's clearly a PUPD cat with very dilute urine, and the owner said the only change they noticed was that they saw her drinking a couple of times. They didn't perceive it as excessive, but in hindsight, they'd never seen her drink before, and now they had. So it can be these very subtle historic changes that could suggest chronicity. But in this case, none of that was present. Some cats with suspected AKI, when we're looking to see if there could be a more chronic uh, underlying cause, they will be things like anemia, which much does suggest that this is more of an acute on chronic. But our ultrasound is more consistent with a chronic kidney disease, perhaps with some current inflammation. And I'm sure you're thinking of differentials such as pyelonephritis as well, which is certainly possible. Always be aware again and talk about taking drug history. And drug history can be important because we can see, as we saw in the first case, immunosuppression causing problems with infectious disease. But we can always see drug reactions, and we're not very good at always recognizing them in cats, particularly. But any antibiotic can cause all sorts of things. And actually, I had a good look at some literature to see whether cephalosporins have been implicated in acute kidney injury. And pretty much anything can cause acute kidney injury if you go through all of the human literature. So possible, but seems very unlikely. It's not really reported in cats. And what about this hypercalcemia? Is it the hypercalcemia itself that is causing an acute kidney injury? Well, we know that hypercalcemia is not a friend to the kidneys at all. But what came first? Cats with chronic kidney disease can also be hypercalcemic, but we don't usually see such a level of ionized hypercalcemia. So the nuance of medicine, also looking at the level of increase of parameters, because that can be quite important as well. But if this hypercalcemia has been long standing, we don't see any uroliths or mineralization that might suggest that it was there before the development of any kidney injury. So, what are we going to do with Maisie? Well, we did some initial management of her case, so kind of checked that we could give her some little bit of extra fluids, monitor her urine output, which is not always easy. We could have placed a urinary catheter, but as you probably saw in those previous videos, she was actually relatively well and therefore moved a lot, and we were quite concerned she would pull out a urinary catheter. So we were weighing her litter. We did do a short GA to place an O tube and a central line, and that's because a case like this, we can foresee we're going to need quite a few blood tests and we're going to need quite a lot of intravenous medication, and having a central line is super useful for that and actually relatively simple. Do we need antibiotics? Well, we mentioned that potential kind of reactive fat around the kidneys, but we don't have any evidence of that the fluid within the renal pelvis looked particularly hyperechoic or anything else. Very mild pelvic dilation, but not very much. So at this point, we have got a mild neutrophilia, mild to moderate neutrophilia. We held off for now while we worked out what was going on, and while we were pending urine culture. So, what about this hypercalcemia? Let's go into this in a little bit more detail. Well, we've got with it a hyperphosphatemia or a normal phosphate, and interpreting calcium with phosphate is particularly useful in hypercalcemia. And I won't talk at length at that, because if you look through the webinars on from International CATK, you'll see a brilliant webinar about hypercalcemia that will tell you much more than I can in this short time. But let's just say that it's persistent as far as the ionized hypercalcemia, but the fluid therapy has brought it down a little bit, and it's brought the creatinine down a little bit as well. So her azotemia is sort of stabilized and stuck, and that's what happens with some cats with acute on chronic kidney disease, particularly. They'll sort of go up, go down, and then you can't get it to move anymore. And so with Maisie, that seemed to be what it did. And actually, her appetite dropped a bit. She had been eating a little bit better during the sort of middle period, and then she stopped eating. But her eyes and nose are normal, so it's very hard to relate what was going on with that upper respiratory tract. We added some appetite stimulants. The calcium shot up again as soon as we reduced the fluids. And so, to cut a long story short, we did some further investigation, including measuring parathyroid hormone and measuring PTHRP as part of kind of investigation of that hypercalcemia. But we're still very unsure whether it could just relate to her renal disease. And you can see that her parathyroid hormone is particularly high. And you might still say, well, okay, but chronic kidney disease cats can have they can essentially have renal hyperparathyroidism. And so we looked at a lot of the reference intervals for a pure renal cause, and it's possible, but it didn't seem quite likely, but it would explain why the phosphate was either normal or high. So still trying to untangle what was going on there. But what did I miss? Did I miss anything in this case that could be useful for cats with non-specific presenting signs? And that's a full clinical examination. So my first case was telling you about history errors, and this is my admission of physical examination errors, and this is what I missed. She actually had a mass affecting her right parathyroid, and it was a little bit lower in her neck. It was lower than the thyroid region, I think because it was big, it had dropped down, and therefore it wasn't obvious on palpation in the region kind of around between the larynx and the thyroid. And then she had quite quickly during her hospitalization a central line placed and an O tube, and we would tend to place them with the patient in lateral, so we wouldn't again necessarily palpate that region of the neck. And she then had lots of dressings on her neck, but that's no excuse. I did not effectively palpate all the way from top to the thoracic inlet, and I missed a parathyroid nodule. If I had felt that cervical mass, I might have avoided quite a bit of time and debate about whether CKD was the cause of the or AKI on CKD was the cause of the hypercalcemia. I could have more rapidly managed her underlying disease. I could have saved money potentially then, And we could have moved to perform a parathyroidectomy much earlier in the course of her disease, although, of course, we still needed to manage her AKI. And you can see her surgical photo here with a very big and obvious mass. Post surgery, she did very, very well. We monitored her calcium and it dropped to 1.1 relatively quickly. I think that was the day after surgery. Hospitalized her for a few days to make sure she didn't go hypocalcemic, which she did not. So the diagnosis in this case was a parathyroid adenoma affecting her right parathyroid gland. And 6 months later, she was doing really well. Her creatinine has come down, actually further than I thought it would, to be honest. She's got a normal ionized calcium and her chronic kidney disease is stable. So it all ended up okay, but it emphasizes the importance of your hands and your eyes and how important they are in investigating cats with non-specific clinical signs. And I put a few images here to remind me to talk about certain aspects of it. So things like examining the oral cavity can be really difficult in conscious cats, and we can miss things that way quite easily as far as dental disease, but also things like mucous membrane color, hydration, etc. If we look at this cat in the middle here, this is a cat that was presenting with nasal discharge, and there's a clue in the physical exam that would suggest that perhaps this was not just a localized chronic rhinitis. And so the keen-eyed of you might notice that we've got an isochoria here. That's important because that suggests, obviously, that we've got involvement of other areas apart from the nose, because otherwise we wouldn't have Horner's or this anisocoria present. And then just a reminder to check parts of the body that we don't always look at in our quick physical examination. And that's things like the retina and the eyes. And I do a lot of work with FIP, and I'll always tell you, if you ask me about reaching a diagnosis, is have you checked the eyes? And that's because identifying uveitis or chorioretinitis, for example, is a real useful red flag that costs nothing. We're using a slit lamp here, but you don't have to. You can just use an ophthalmoscope and look at either indirect or direct ophthalmoscopy. So, my take homes from Maisie, well, the importance of a clinical examination and considering things might not be quite where you expected or what you expect. And having a really methodical approach, even when you're busy, can mean that you don't miss some of these things. So, having your standard way of working through a cat, and applies obviously to other species as well, means that you won't miss things. And it's when I've cut corners that I have missed things. But demeanor can be important here. So we know that when cats are very stressed or they're showing any kind of behavior that means we can't do our full examination, that's really, really challenging. And then we might think about using things like anxiolytics in order for us to do full examinations. But we have to then be aware that anxiolytics could affect our physical exam. We know that gabapentin can affect, probably does affect blood pressure. We don't know what it does to hypertension, but it certainly does affect blood pressure, particularly in cats that have chronic kidney disease, for example. And we also know it affects, for example, neurological or orthopedic examinations. So it's something that as cat vets, we've got to get around and find our ways. And of course, I'm going to plug Cat Friendly Clinic here because that does allow us to do a kind of clinical exam in the base of a carrier, for example. That can immediately reduce some stress. We can sort of cover with a towel certain areas and expose the areas of interest whilst we work around our patient. And so there are lots and lots of ways that we can complete our examination without missing things like I did. Okay, let's go on to our third case, and this is another beautiful cat, a Burmese cat here, of 8 years of age, and she has again a really vague history. She's got a 2 week history of not interacting with her owners as much as she does normally, and that's all. She normally follows them to the toilet and follows them around, and she's not been doing that, and that's what they notice. But that's all. So again, change in behavior is always a sign of something. It might be a sign of even just stress, but it can also be a sign of pain and illness. And so another red flag for me is sleeping in unusual places. And I hear that quite a lot. So they'll just say, well, like in this case, they usually follow me to the toilet and things. But they also said they found her sleeping under a bed and not in her usual place. And cats are quite creatures of habit. Yes, they will, of course, change their routine, but to adopt a totally novel sleeping place, particularly away from what they prefer to do, then that can suggest that we've got a problem. She's eating okay, but she does look a little thinner. The owner thought around her back end looked like she'd lost a little bit of muscle. So there's not a huge amount to go on there, is there? You might also be thinking, well, hold on, you didn't give me the full history. And, I just told you to get a full history. So let me try and correct that. She's the only cat in the home. She's indoor only. She eats a complete wet and dry diet that's a manufacturer, about 50% of each. She's up to date with her preventative health care. She's no travel history and she's on no medications. So we examined her and it was pretty unremarkable, but she'd lost, compared to previous weights where she'd been in, I think, for a vaccination, she'd lost about 300 grams, which is quite a lot for a cat. So let's have a look at some bloods. That's usually our next move, isn't it? When we are starting to formulate our problem list and differential diagnoses, we're going to reach for some bloods. Now, ideally, that is led by clinical signs and physical exam. But in a case like this, we haven't got a huge amount to go on. So we probably are going to do a slightly more broad biochemistry panel. And you can see that there are no reds here. Her biochemistry is normal. But again, we always notice within that, so within normal parameters, we can see things. The creatinine is within the reference interval here, but that would be, if you look at the iris staging, actually kind of getting there from a creatinine point of view. And that's quite challenging for you and I when we interpret results from different labs. And a brilliant recent paper in JFMS looking at how we would interpret things a bit differently in with results from different labs. So try and use the same lab, particularly when you're looking at trends within an individual patient. On the hematology, well, we've got a mild anemia that looks pretty non-regenerative. You can see that. So nothing too much to go on. Mild lymphopenia and retroviruses are negative. So we're not getting a lot here, are we? This is quite a non-specific presentation and non-specific findings on bloods. So what next? Well, we've still got multiple differentials. If I asked you to write down all the differentials for lethargy, mild weight loss, and maybe kind of change in behavior, you'd come up with a pretty long list that involved all different body systems from the brain to the urinary tract, for example. So, what can we do? Well, we certainly could get a urine sample, that might be helpful. But I also sometimes will come back and try and repeat the physical examination, and you might notice something a little bit different. And so, in this case, between examinations and waiting for bloods and things, just thought maybe we've got a slightly elevated respiratory rate in the consult room that wasn't noticed previously. And that's something we're going to grab onto and start to investigate. And you can see here that that actually was a very fruitful thing to investigate because despite her having only a very slightly elevated respiratory rate, she does have a pleural effusion that you can see us having a look for here on POCUS. And you can see there that her respiratory rate is not too exciting. Cats can be quite surprising, I think, with pleural effusions. I had another cat recently that I would have sworn blind to you that cat did not have a large pleural effusion. The owners were so diligent, they'd been documenting respiratory rate kind of twice a day, and that cat's respiratory rate was between 25 and 30. But yet we removed about 100 at least 100 mils of fluid from that cat's chest. So again, I think masters are limiting their own activity to not exhibit those clinical signs. So POCUS can be really helpful in non-specific cases. I'm always going to tell you that POCUS is a useful thing. I love a bit of POCUS. And the other brilliant thing about POCUS, as far as non-specific clinical signs, is that it can lead you in a useful direction. And we can do it very much conscious and we can do it in a very, very cat-friendly way with very minimal restraint. And so there's no need in many cases to completely sedate cats for this type of procedure. We can do it in the base of the carrier. But once we've identified that there are abnormalities, then if there is free fluid, we've got a direction. We can sedate that patient. We can go ahead and we can take samples of that fluid, and that can be really, really useful. You can also see on this video on the right, we've got some B lines, and detection. If you're not familiar with POCUS, please have a look at the brilliant cat-friendly POCUS article in JFMS, which take you step by step through performing these type of examinations. And you don't need one of these handheld. We're very lucky. We've got some of these very nice kind of hands-free little ultrasounds. You don't necessarily need that. You can do that with your normal machine. But we can see some B lines which suggests we've got wet lungs, and that's hugely valuable in many ways, obviously diagnostically, but also in monitoring fluid therapy, for example. So, yeah, get the ultrasound out in these non-specific cases. You might want to then follow up with a more complete ultrasound, and we did in this case. In Thea's case, we wanted to know a bit more about why we had fluid, and so we went ahead and we did do an ultrasound and found some peritoneal fluid as well. That's very useful. If you find fluid in one place, look for it in other places. And some very abnormal looking jejunal lymph nodes. So these jejunal lymph nodes, they look massive. Actually, it's very magnified. They weren't enormous, but they did look quite abnormal. Of course, we sampled that fluid that you saw. That's going to be both therapeutic and diagnostic. So here we've got some of the fluid. So it's got a yellow tinge. You're probably thinking, oh, it's me. She'll be talking about FIP. Well, it's certainly a differential, isn't it, for a few non-specific clinical signs and a bicavitary effusion. In this case, it was did qualify as a non-septic exudate, although I thought it looked a little bit dilute. It did have a reasonable amount of protein in it. It had a mixed cell inflammatory pattern, and the albumin globulin ratio was 0.7. So what do you think? Do you think that that is enough for us to suspect FIP? Well, actually, though I could bore you for hours talking about FIP, albumin globulin ratio is so useful, because this albumin globulin ratio is just too high for FIP. Never say never with FIP, but it would be really unusual. Cats with FIP will have an albumin globulin ratio on their effusion of less than 0.4. And so this just looks too high for me. And so this, once I got that result, I was just like, I'm not ruling it out, but it doesn't fit for me. And have a read of some cytology results here. So the other take home would be to sample everything. Taking needle samples is a low risk thing to do. Yes, I understand it has some cost associated with it, but sampling more than the fluid is, this case is a good example where if we just submitted the fluid and that had taken a couple of days to get results to come back, we would not have got a rapid diagnosis that we did in this situation. So because we'd sedated her in order to drain her chest, we sampled fluid from her abdomen, and we also took samples of those abnormal lymph nodes and the spleen and liver. And so sometimes in non-specific cases, you'll find some very vague ultrasound findings, such as mild lymphadenopathy. Maybe the liver just looks slightly heterogeneous. Maybe the spleen looks slightly heterogeneous. Actually, taking samples is often quite fruitful. And as I would say to owners, even if they come back as normal, that has been helpful, because I haven't found something like a load of inflammatory cells or a load of neoplastic cells. Now, FNAs have their limitations, don't get me wrong, particularly in things like liver disease, but we know when we're looking for when we're investigating non-specific clinical signs, it will at least move us forward. Okay. So in this case, actually quite a sad situation of a nasty round cell neoplasia. And we had some further kind of staining and testing, and it looked like a histiocytic sarcoma, which is particularly horrid and unusual in cats type of neoplasia. So that albumin globulin ratio was what gave me that kind of heads up that this wasn't potentially not an FIP case. So the take homes that I have from this case for you are thinking about which tests are going to provide you the most information. And I call them high yield tests, but I know one of my American colleagues, she said, oh, you mean the bang for buck tests. And I quite liked that, because we were talking about use of client funds in the best way possible. It's very rare that we can just splash out and kind of run every test, and we shouldn't do that. That's not good medicine. But tests like running a PCV and total solids as an initial investigation. POCUS, yeah, I'm always going to talk about that. checking left atrium in dyspneic cats, that's a very high yield test. So if you can build up your confidence to do a POCUS and a left atrial check, you would almost have all the information you need to treat every dyspneic cat that comes in the clinic for quite a small amount of funds. Sampling fluid, if it's present, even if it's a little bit, try and get some, even if it's a drop that you can put on a slide and send off to the lab. I am quite a fan of B12 and folate in GI cases because they're relatively inexpensive to run, and they immediately tell me if I need to worry about malabsorption, for example. And so I find them quite a high yield test. And I think FNAs have great limitations, but when we're talking about approaching non-specific cases, when we don't expect it always to give us a diagnosis, it helps us to narrow our lists. And there are some things that are less helpful and will cost up money and are unlikely to narrow your list. And abdominal radiographs, yes, they have utility. They do, don't get me wrong. But in these type of non-specific cases, I would say that they're less useful because we're not looking for something like a foreign body. You know, we haven't got in a case that does not have primarily vomiting as a clinical sign, for example, your abdominal radiograph is going to be a lower yield test. Things like serum protein electrophoresis in hyperglobulinemic cats. Now, lots of people do like running this. If you're not familiar with it, this is working out basically whether you're dealing, what type of gammopathy you're dealing with, a polyclonal or monoclonal. And you might say, well, that sounds like a really sensible thing to do if you've got high globulins. But the fact is that monoclonal gammopathies in cats are vanishingly rare, and they have been reported with both FIP and things like multiple myeloma and other plasma cell neoplasia. How often have you seen those? How often have you seen plasma cell neoplasias as a cause of hyperglobulinemia in cats? It's super rare. So you're most likely going to submit that and get a polyclonal gammopathy result. And that's not going to be moving you any further forward. So that funds could have potentially been used for doing some scanning, for example, doing a POCUS. And always think about things like titers. So we mentioned toxoplasma titers as having some limitations, and they certainly do. And you know that I don't like coronavirus titers. There are big issues with measuring coronavirus titers. They can stay severely elevated for some time after exposure to coronavirus and have no or virtually no utility in the diagnosis of FIP. And the same can be true for other kind of antibody testing. I mean, some unusual things like Bartonella, for example, that could just indicate exposure. Having said that, a negative titer that can be more useful because if we have a negative titer, then we know that exposure to that disease as a cause of the current clinical signs would be less likely. So I guess you might convince me in some of those situations. So we don't always need the advanced imaging and the CT scans at all. We can get a ton of information from targeting some diagnostic tests. Okay, here's another case for you. Going back on the ages here, we've got a Hudson who's a 6-month-old British Shorthair. He is an only cat. He's he's up to date with preventive healthcare, and he actually got neutered a week ago. He's fed a Royal Canin kitten diet, so nothing abnormal there. But for 3 days, he's been lethargic. He's got a bit of a change in his meow, the owner reports, which is a little bit strange. Just said it was higher pitched. And he's hyperexic, progressing to being anorexic. So, busy slide here, apologies, let's work through it. So, the blood showed a mild non regenerative anemia, a mild neutrophilia. So, all again, relatively non specific, a mild hyperbilirubinemia. Now, that sounds a bit more useful, doesn't it? We've got some differentials for that, but it was quite mild. And we did the POCUS. You know, I like a POCUS, no free fluid in the chest or abdomen. He did end up having a full ultrasound of his abdomen, which showed some enlarged lymph nodes. So that is something, useful, but becoming, narrowing things down. But the FNAs just showed some degenerate neutrophils with no bacteria and described it as being consistent with aspiration from an abscess. Now, why does he have an abscess and a lymph node in his abdomen? Well, quite appropriately treated with antibiotics. And when there was no response, they were sort of escalated. So adding a fluoroquinolone to amoxiclav over these last couple of days made no difference. And what happened? Well, he was referred, and we certainly did find these enlarged jejunal lymph nodes, but we also found free fluid. And I'm sure that when that vet who referred that case read the reports, they thought, damn it, did I miss that free fluid? And the answer is no. Just remember that things change, diseases change, clinical signs change, and things like the presence of free fluid will change, as it did in this case. So, therefore, to diagnose his disease, all we did was sample that fluid and ran various testing, and everything was consistent with FIP. And so, I think that aspirate was just from the center, kind of a necrotic center of an enlarged lymph node. So, things do change. Repeating things is not a bad thing. Sometimes owners don't understand this. And I had a client this week, and the cat had an ultrasound 6 months before. And they sort of said, well, why would you repeat the ultrasound? And I thought, well, it's a fair question. I get it. But we have to explain that actually repeating things, even within a few days, is valuable because the evolution of the disease is so helpful for narrowing that diagnostic list. And I always really love these type of graphs that show the pattern of diseases, because I find this really useful when I'm thinking about some of these odd ones, because we know that neoplasia will progress and get worse. We know that generally infection will get worse without treatment, but you might see some change in pattern with antimicrobials. Inflammation, on this graph that I put in here, it sort of has it as going upwards and upwards. But I think actually inflammation and inflammatory disease can wax and wane. It's probably influenced by some other factors like stress, etc. And anyone with a chronic inflammatory disease will say there are good days and bad days. Metabolic diseases can vary according to like if they're fed or they do exercise, so there I find this kind of pattern, particularly in chronic cases that I get referred that have got a long history, that can be really useful. So lack of response to treatment can also guide me in the direction that I'm going to take. Okay, let's move on to the next case. This is Boo, who's a 4-year-old male neutered ragdoll. He's been with his owner for 6 months, and he's showing some slightly unusual behavior. He was rehomed because of a change in circumstance, so doesn't have a long medical history particularly, but he has started just occasionally attacking the owner. And there doesn't seem to be any reason for that. He's an only cat. He is an indoor only cat, and that could have some significance because previously he has been an outdoor cat. So again, a nuance of kind of change in environment can be a clue. But he is doing some dangerous things. He's caused some injuries to his owner. He also is described as being quite lethargic, and he very occasionally vomits, but that's not a consistent part of the history. And importantly, we were told that he cannot be examined in the clinic. There's no way that we'll be able to do any form of examination on him. He does not like the veterinary clinic at all, and he has been trialled on gabapentin in the past, which made very little difference to that conclusion. Now, he was referred to both medicine and neurology, I think because his presenting signs were so vague that we didn't quite know where to go with him. So, what are you going to do next? How are you going to approach this cat that we cannot examine? Yes, we can take some bloods, of course, but we are starting from a bad point of kind of vague clinical signs and no physical exam. And that can lead us to problems if we start indiscriminately running tests. We've got to try and find some direction to follow. Otherwise, we'll also use up quite a lot of money doing that. So, what I did was I asked the owner if they would send a number of videos pre referral so that we could examine them with our neurologists. We could see, because one of the suspicions and concerns was whether there was a central pathology causing behavior change and lethargy. For example, has this cat got intracranial disease, and that's why it's behaving so weirdly? For us to see the demeanor of the cat at home is valuable, as well as its mobility, because a cat with a space occupying lesion is unlikely to be completely normal between episodes of attacking the owner. That would be very unusual. So we asked for some videos, and the owner, I was quite specific. Also, I asked them, say, video him going up and down the stairs. Here he is coming upstairs. And bear in mind, it's a 4-year-old cat. Don't know what you think of that. Here he is. We can also see some interaction. We're assessing vision, we're assessing demeanor, we're assessing mobility, all of these type of things. Mentation looks pretty normal. Sight to a certain extent. Here's another video for you here. So I did have to read a lot of videos. I said, try and get him moving. Let's see him moving. He's chasing a toy. You've got your own thought. Have a think what you think. He can jump, so you can coordinate. There's no clear issues with balance or ataxia. We can assess his coat. I did a little bit of playing there. See what you think. Are you thinking anything particular? This could go on sometimes. So he can jump onto, let's watch him jump onto here. I would say try and show me some different activities. So him jumping on and off sites that he likes to go on. A little bit hesitant. Jumps. Okay. Another video here for you. So there's a good leap there. Landing on his sort of all four legs. So again, sight seems absolutely fine, doesn't it? Coordination, no proprioceptive deficits that we can see. He interacts pretty normally with his owner. Okay, so did you notice anything about his gait in those photos? Well, I certainly felt, and our neurologist felt, that he showed no neurological abnormalities, but he did have quite a stiff and stilted gait, and he was quite hesitant to jump. He was quite slow to go up and down the stairs. His forelimbs looked particularly normal, but his hind limbs did look stiff, and I thought possibly a lack of muscle as well. So we were still unable, despite gabapentin, to examine him in the clinic, and we felt that the utility of that was going to be very, very minimal. We had a lot of information from these videos, so we just observed that his mentation was normal. His hair coat wasn't brilliant. As a 4-year-old cat, should have a very shiny coat, and there's some loss of muscles over the hind limb. So this was really helpful because we knew we couldn't do any conscious exam, but we could sedate him and examine him fully under sedation, like his oral cavity, his, abdomen, listen to his chest. We can do our physical exam in that way, but of course we can't assess pain. But we could detect that loss of muscle over the hind limbs, and that led us to take some radiographs, as you would expect, and he's got significant and severe bilateral hip OA. Now, this is undoubtedly causing pain, and we know that pain has a connection clearly to behavior. And so, in this particular case, we felt that the episodes of aggression were probably associated with pain. And when I watch those videos again, I see that he can jump, and I see him jump, but he jumps, he lands, and then you'll see him then hesitate and sometimes withdraw from the playing, probably because it really hurt for him to land in that way. And when he was treated with analgesia, his episodes of aggression resolved. And interestingly, his vomiting seemed to resolve as well. And remember, pain, stress, GI, all can be linked together. Now, later on, this poor cat did develop some other aggression problems, potentially related to us not getting on top of his pain. His hips were really, really bad. But yeah, the take homes from his case are that videos from home are much more likely to show you the cat's normal behavior. I mean, normal as in normal for them, than what we see in a consult room, even if we have lots of time. In a situation where we have very little time, that's even more challenging. We can think about looking at gait. We can look at neurological problems. If people describe gagging, coughing, retching, we can look at all of those. I'm often presented with cases that are reported to be retching and have a GI problem, that actually are coughing, that have a respiratory problem. But they don't, well, I'm not going to do it in a consult with me. I'm not going to see that behavior. So, but be specific, otherwise you might end up with a ton of videos of the cat just sleep or something like this. So make sure you ask them for what you need. Here's another case. This is Buster. Now, he's another British Shorthair. I've shown you a couple of these. I seem to be showing you pure breeds, not by intention. This is a 10-month-old male neuter British Shorthair. He's been with his owner since he was a kitten. Now, he has got some red flags. He's on a raw diet with some kibble. He's indoor only. He's nothing else remarkable. So the red flags are starting to kind of form in that we see that raw diet there. But again, we want to also remind ourselves not to go into a case with bias. So I don't know about you, but if I hear raw feeding, I've already decided I'm going to need to test for X, Y, and Z. And that actually is unfair the other way. We shouldn't assume that raw fed cats have an infectious disease. So he's got a 5 to 7 day history of lethargy. They describe some mild tachypnea, some weight loss. He's had bloods a couple of times now, which are unremarkable. It had some radiography, which showed kind of some slightly reduced serosal detail in the abdomen, but that was associated to having a reduced body condition. Can't rule out fluid. So again, this is where that kind of radiography is not always hugely helpful. Now, on physical exam, he was quite quiet, and for a chunky British short hair, he had lost some muscle mass. And when we palpated his abdomen quite deeply, we thought possibly we could feel a mass that hadn't potentially been felt previously. Nothing else very exciting, but he is mildly pyrexic, so that was of course important. Did repeat some bloods, and again, relatively unremarkable. Hematocrit is at the bottom of the reference interval. So again, not just looking for the red, but looking for the figures is very useful. We did some imaging of these masses, and we can see that we've got an ileal mass, and we had 2 masses within the jejunum. So I'm sure you're starting to think about what might be going on. Well, I did even more so when I saw that there was a pleural and peritoneal effusion and a sternal lymphadenomegaly. So we seem to have quite a diffuse lymphadenopathy here with effusion in 2 cavities in a young British shorthair. So our problem list comes back to that. We drained actually quite a bit of fluid in the end, and he's pyrexic. And this is a cost-limited case with what we've already done. We've burned through quite a bit of the funds. What is the best next test, or should we be trial treating? And that can be a point in an investigation that is really, really challenging. But again, I think fluid cytology is a minimum in a case like this and is a very good use of funds, as we mentioned. And so that sample of fluid from both the thorax and the abdomen, and we could look at that in-house, which would save money, and we can run it through an in-house machine to get an albumin globulin ratio. So we can do a lot in clinic that will prevent delay and save funds. Should we take some FNAs from those intestinal masses? Should we take some FNAs from those lymph nodes? Well, I told you earlier, we should probably also sample the liver and spleen, but now I'm starting to give you quite a big lab bill. We did end up sending off the fluid and taking samples of the intestinal masses as a compromise, but you could also have sampled the other regions and just examined them in-house. And usually that's less expensive than sending multiple slides to the lab. As soon as you send a lot of slides, the charging will go up. So always choose your best slides. And that means looking potentially at one in the clinic. Even if you don't quite know what you're looking at, you and I can tell if there's good cell yield that's not just blood. There's a good way of working out the best and most optimal slides to send to the laboratory. And what you can see in this situation, this cat has lymphoma. And that might surprise you. It certainly surprised me. And I even was so surprised that we added some immunocytochemistry to make sure that that was the diagnosis. And I suppose he taught me a little bit, Buster, to challenge my pattern recognition tendencies that we all have. And we always talk about, horses being common and zebras being unusual. And he is certainly a zebra. And that means that if I'd seen 10 cats like this, 9 of them would have had FIP, and treating them without further diagnostics would have been appropriate. But it also reminds us that sometimes when we cut corners, we can miss critical diagnoses and critical diagnostic steps. So what I'd advise you is to steer around the corners rather than cutting them. And what that means is sometimes taking a sample and not sending it off, but storing it in case things don't quite go as planned. So on my desk, I have a collection of slides from various patients just in case I'd need them later if they hadn't responded as I'd expected. So, for example, in Buster's case, if we treated him with GS, he would have not responded at all, and then I would have had to potentially readmit him for further cost, and then run those tests at that point. And so, taking those samples while I had him sedated in front of me made more sense. And it is a balance of over testing for weird stuff, which I'm also not going to advise you to do, versus missing things. If I go back, you might notice another red flag, that albumin globulin ratio, again, like that other case that I showed you, it's too high for FIP. So look for those little clues that might mean yes, this is worth submitting that further test. So he certainly taught me a thing or two. Okay, our final case is Sasha. Sasha has been the most challenging case that I've worked up for some years. I will have lots of photos of him, and I haven't quite fixed him yet. But he's a 2-year-old male neutered Abyssinian. He comes originally from Japan, so that's really important travel history. It was a year ago, so someone may not mention it. We need to ask these questions. He is an indoor cat on an unremarkable and complete wet and dry diet. And he's got a long history, a 12-month history of waxing and waning weight loss, to reduce demeanor, some other sort of very non-specific clinical signs. And at the beginning of that illness, he was treated for FIP based on having some enlarged lymph nodes in his abdomen and having high um, serum amyloid A. So, serum amyloid A, if you're not familiar with it, it's an acute phase protein that we sometimes look at in FIP, but it does tend to go up and down a little bit more. We do prefer to look at AGP. Now, that treatment resulted in a minimal response. They thought initially maybe he improved, but it certainly wasn't maintained. And this SAA has just gone up and down, been monitored several times over the coming year. Recently, that SAA went up quite significantly again, as did the AGP when it was measured. So he was treated with GS for another 12 weeks. Very non-specific clinical signs still, so just that mild lethargy. He had lost further weight, and he just was not right. He was a cat that had stopped playing and wasn't very interested in things. He'd had a little bit of diarrhea, and he'd been treated with some doxycycline most recently, just sort of with a view. Developed a little bit of anemia that I'll tell you more about, and so he'd been treated with doxycycline as something to consider. On examination, he's got a mild lymphadenomegaly and particularly firm popliteals, which is something you don't feel every day in cats. So I did feel that was quite something to notice. He was in quite a slim body condition. He had actually an intermittent gallop, and the owners had noticed some tachypnea, and he'd had some episodes when we looked at some videos of more significant tachypnea. So Sasha has got quite a long problem list, and I'm not going to take you through every investigation because we could spend an hour talking about this one particular cat. But I'll just show you a video here. You can see he has got certainly some increased respiratory effort as well at this point. So he sort of rotated between having some tachypnea and some increased respiratory effort. On some bloods, you can see some bloods here. He was anemic, so he's got a hematocrit of 17 at the lowest and quite a high reticulocyte count with some agglutination. He had some cardiac workup because of that gallop rhythm that showed he had some changes in his heart, a mild left atrium enlargement, and a quite severely elevated troponin. So that suggests there's some inflammation there, some myocarditis. So Sasha can send you off in all different directions and lead to very expensive investigation. And don't get me wrong, we still spent a lot on what we did. But let's try and formulate a problem list and then kind of work through. And so we end up with some non-specific signs such as weight loss and his lethargy. I haven't even added on here. He's got some diarrhea, he's got some tachypnea, he's got this lymphadenopathy, which on aspiration was pyogranulomatous. He's got myocarditis and he's got a regenerative anemia. Now, that's quite a collection of tests that we could do to investigate each one of these different pathologies. So let's remember the history taking. Let's go back a step. So remember, we're going to ask about diet. Well, we've got no history of raw feeding. There is a travel history. Now, is that significant? We can easily these days Google or ask AI, anything like that about infectious diseases in a country that we're not familiar with. And so I certainly did that. I certainly looked into pathogens, and you'll find that a lot of countries have got some nice studies looking at prevalence of infectious diseases. So you can often find out how prevalent certain conditions are in different countries by looking using things like Google Scholar. He has had treatment with 2 courses of appropriate dosage antivirals for FIP with very minimal response. And that's a very useful bit of history. I think that makes FIP not completely excluded, but highly unlikely. We've also got to think that he's currently on antibiotics, so I need to take that into account if I'm going to perform, for example, any cultures that could be affected. But it's doxycycline, so essentially less broad spec than some other antibiotics. And let's also look at the evolution of his disease, as we talked about before. So the progression is pretty slow. They do feel he's generally worse now than he was a year ago, but he has ups and downs and he's still alive and he has a year history of illness. So that in itself is useful. And then also remember the signalment. So I've shown you quite a few purebred cats today, mainly out of coincidence, actually, but also by importance to remind us that purebred cats, just like purebred dogs, can have inherited diseases, and Somali cats can have inherited diseases. And we don't see them very often in our clinics. Somali is not hugely common in the UK. Lovely cats, actually. They should be more common, I think. But we can, again, do a Google. We can look in a textbook. We can see if there's anything that Somali cats get that could explain things. And actually, Somali cats get pyruvate kinase deficiency, which is a cause of regenerative hemolytic anemia. So I thought I was onto something here, and I did send off a genotype test, which are actually relatively inexpensive tests. We send them to Labaclin. Um, Depending on where you are in the world, you might have some different labs, but Labaclin will offer some really nice testing according to breed, which they do for dogs and cats. And in this case, it was actually negative for PK deficiency, but it was a good thought. So we did do some further investigation, and you're probably thinking about all sorts of differentials, and that's really good that you are. I hope I thought of most of them, but retroviral negative, the ZN staining for Mycobacterium was negative, hemoplasma negative, Bartonella negative on PCR and serology. Toxoplasma antibodies were negative. We did actually need to do a PCR on BAL, which is negative for toxoplasma. There's no fungal infection on the samples, no evidence of neoplasia. Aspirates of lymph nodes were pyogranulomatous, and this cat is getting worse. So we did some further investigations, thinking about what would be the most useful most useful use of funds at this point. I was reluctant to do a ton of treatment trials, but we knew we may have to. And we were poised to use, for example, a different antibiotic for an organism we were not aware of and we hadn't found, and whether we did need to use some immunosuppression because of what looks like a hemolytic anemia. But actually, what we added on at the end was a gamma interferon test for mycobacteriosis. And if you're not familiar with that, it's a test on blood that is run in the UK by a lab called BioBest. And what they'll tell you about is that kind of immune response to mycobacteria. So, of course, we can send off tissue samples, we can do PCRs, and our next plan was to potentially remove a popliteal lymph node to submit for that type of testing. But we got a positive for non tuberculous mycobacteria on this particular blood test. And that was obviously very, very useful. And we knew that in Japan, there certainly are some types of mycobacteria which are reported in cats and to cause this type of presentation. M. avium was certainly another differential for causing those mixed signs. So my take home from Sasha really was when you have more than one body system affected, or you have more than one kind of distinct pathology going on, such as in this situation, an IMHA plus a pyogranulomatous inflammation of the lymph nodes, myocarditis, we've got to think about whether one condition explains everything, and if it does, which one that is, or how likely is it for this cat to have more than one condition that are explaining the clinical signs. And certainly cats can have more than one condition, and particularly